Hello and welcome to the learners of the NPTEL course on Economics of Health and Education. Today is the second live interaction of this session. I hope you can pose some questions as part of this live chat. You can put your questions on the YouTube live chat, or you could also put your questions on the Google Drive Excel sheet that has been shared with you. I'm yet to receive any questions from the learners. However, since I believe that you are now in the second part of this course, so you should have moved towards week 9 of this course. Let me take you through to what was the intention of this course and give you a snapshot view of how far we have come along in the course and what are the things that we have covered. So then possibly you could, ask a few doubts or questions that you may have from these modules. So as you all know that this course is a 12-week course, and it is meant for beginners to students or learners who would like to begin research in the domains of health and education. And the broad contours of the course follows the economics of health and education. However, since it is meant for a wider audience, I have designed the course in such a manner that undergraduate students and postgraduate students can also enroll in this course. And so the course has been pitched at a level where even undergraduate students can make sense of some of the basic understandings about health and education economics, while at the same time, learners who are interested to take up master's dissertations or PhD level dissertations in this area can take the theories, data sources, different kinds of conceptualization of what is it that we are investigating when we are studying issues in the domains of health and education economics, will also find this useful. So the first 4 weeks of this course, we tried to look at the foundations. So for example, in week 1, we tried to understand what are the links of health and education to human development. And the concept of human development, the understanding of human development applies to many social sciences, including economics, sociology, political science, for those conducting research in the field of development practice and development studies. So the idea of linking health and education and the economics of health and education to human development is precisely to help researchers in all of these fields, diverse fields, understand what are the interlinkages here and what are the different intersections at which different social scientists can work. So we looked into the details of how the human development literature has considered some of the important parameters and indicators of health and education, outcome indicators of health and education. And so then, different outcome indicators can be worked out in this context, and students can take it up as research. In this week, we also made a distinction between human capital and human right, because often when we look at health policy frameworks, we will see that there is a fine balance that is tried to be maintained between health and education as investments or health and education as a right in itself. So it is in this context that we had a discussion about how do we view these kinds of domains when we are trying to invest in education and health. Should we look at them as mere investments, or should we look at them as something more than investment, something which is intrinsic and important for human existence itself? In week 2, we looked at some of the unique aspects of health markets, how it differs from the standard economic benchmark of perfect competition, and how health markets differ from perfect competition, how there are imperfections in this market, and therefore we set the foundation as to why health-related matters or health care in general needs to be studied in a context which is a completely imperfect market, and there are various kinds of imperfections both on the demand side and the supply side. So it is here that we discussed some of the issues about externalities, the randomness of the event of being in good health, What are the conditions under which the supply side and the demand side interact with each other in these kinds of markets? That sort of laid the foundation for understanding the demand for health model. And we looked at the Grossman's model for demand for health, which is one of the basic models in that we consider in economics for demand for health. In week 3, we went to the details of this demand for health model, and we tried to understand that while in everyday markets, we deal with different kinds of commodities, and we saw that in economics, we know that there is an inverse price demand relationship. When price rises, demand for a good or a commodity comes down. So we wanted to test whether this kind of an inverse price demand relationship holds in the context of healthcare demand also. So to be able to explain that, we took examples from some of the experiments carried out in the US. We looked at inpatient care, outpatient care, emergency services, elective surgeries, and we concluded in week 3 that in the context of healthcare as well, even if we are looking at outpatient services or inpatient services, with some exception to emergency care services, we do find that there is a downward sloping demand for healthcare services as well. So that was to reflect upon the fact that the standard utility maximizing framework that is used in the context of demand for goods and services can also be utilized to understand demand for healthcare. In week 4, we looked at the supply side of the healthcare market, where we looked into the details of what constitutes the supply side, who are on the supply side. We saw that there are healthcare providers, there are there are suppliers of goods and services on the healthcare. Within this setup, we also looked at demand for health insurance and 2 specific issues associated often with the insurance market, that is adverse selection and moral hazard. After dealing with the basic microeconomic foundations of health in weeks 2, 3, and 4, we moved to the demand for education discussion in week 5, where we distinguished between the basic model of human capital investment. We distinguished between investment in human capital and physical capital. We tried to understand that what are the basic differences between when we say we are investing in human capital vis-a-vis we are investing in physical capital. And in this context, we studied about the production of education and returns to education. In week 6, we looked at a very important categorization that has been carried out in the context of health and education goods. Now, in economics, when we carry out analysis of demand and supply, we often try to distinguish between what kind of goods we are transacting in the market. So we make distinction between normal good, inferior goods, or luxury goods. We also make a distinction between different kinds of goods within the normal good and inferior good classification. On the other hand, we also make a distinction between public goods and private goods, meaning that there are goods which may be collectively consumed and there may be goods which are being privately consumed to the exclusion of many other consumers. So it is in that context we try to look at the role of budgetary policy in the provision of public goods and services. And in that context, we try to distinguish between where do we put demand for healthcare services and demand for education services. One of the lessons in this week exclusively focused on the demand for higher education. How do we classify higher education as, whether it is a public good or a private good or a quasi-public good? And in this context, we also discussed that this classification of goods, particularly in the context of utility enhancing goods such as health and education, is extremely important because often it is a question of financing. We want to distinguish between different kinds of goods because we want to understand how are these goods financed, or in other words, how are these goods provisioned, whether these goods are available in the private sector, whether it is available in the public sector, whether government should interfere and spend more on these goods, whether the consumers who are consuming these goods should get a subsidy on these goods. So these are issues that are very important in the domain of public policy which is why we wanted to look at this economic categorization of education and health goods. In week 7, I moved from the microeconomic foundations of education and health to try and understand this issue of inequalities of outcomes and opportunities. Now, this issue is important because when we are looking at education and health, we have understood that they are not just merely human capital investments, but there is a rights-based aspect to it as well. So when there are rights-based aspects attached to health outcomes and education outcomes, then we need to understand this difference between whether we want to look simply at the outcomes or whether we want to look at the processes of these outcomes, or in other words, whether opportunities exist for accessing these services. And the opportunities for accessing of these services also impacts the outcomes in a very big way. So it is in that context that week 7 we discussed about equity issues. I discussed a classic text by Amartya Sen, a book titled Inequality Re-Examined, where we wanted to understand how to approach this idea of inequalities of outcomes and opportunities. And then in the 2 lessons following the first lesson, I focused on equity in healthcare, where we discussed some important concepts like the Kakwani Index. How do we look at progressive healthcare financing, regressive healthcare financing, and then we moved on to education inequalities in developing countries and India. In the final part of this course, from week 8 onwards, my focus was to lay emphasis on the policy domain. So what are the general conditions for health policy, for education policy? What do we mean when we say there is universal healthcare or achievement of universal healthcare? We also looked at why in India we don't have a rights-based policy as far as health is concerned. We do have a Right to Education Act, but we don't have a Right to Health Act. And we tried to understand what are the arguments and what are the important considerations that has come in the way of achievement of a rights-based policy document as far as health is concerned. We also looked at disease burdens. Why do we need to look at disease burdens? What is its impact on health policy? We tried to see how we can move from a theoretical understanding of health demand functions to actually looking at disease burdens, how we calculate disease burdens, and how that impacts productivity of a country. In this week, the 9th week of this course, I introduced 2 important reports to the learners of this course. One was on the annual state of education report and the other on the public report on basic education. On the week 10, we focused on some of the official statistics on health and education with particular focus on India. In week 11, again, I moved into some theoretical and empirical issues regarding health financing and education financing. And in the final week of the course, I focused on health workforce and women in India's labor market, having discussed that the domains of education and health are very critically linked to how we perform in the labor market. And because employment, unemployment, workforce participation, these are some of the important macroeconomic indicators that tell us about how much the country has progressed. And education and health investments go on to contribute a lot to the labor market. So we try to discuss these linkages between the labor market, health and education, but with specific focus on the health workforce, how we are performing in terms of adequacy of health workforce in India and globally, and also how we are performing in terms of women's workforce participation, labor force participation in the Indian context. So this is again just to carry you through to these weeks to specify what all things we have completed. As I have already mentioned, and at the risk of repetition, health and education and human development, we looked into the policy debate with regard to economic efficiency versus universality and equity. Week 2, we looked at unique aspects of health economics, where we said that healthcare is different because if it requires a lot of government intervention, there's a lot of asymmetric information between doctors and patients. And the element of externalities is also very large in the context of the health markets. In week 3, we went into some details on demand for health, which was slightly more technical than the rest of the weeks. This week, the focus was mostly on how do we look at a demand function for health. And when we are looking at utility derived from health goods, what are the different constraints that we want to look at? Essentially, in the normal goods and services market, when we are looking at a commodity space, we are looking at income as a constraint. But in the context of health, we are also looking at time as a constraint, because as we grow in years, as we age, the stock of health good deteriorates, or there is depreciation in terms of our quality of life. So this week, therefore, was planned as a slightly more technical week, where I wanted to highlight a few important things with regard to how when we are looking at a utility function of health, what are the additional things that we need to keep in mind when we are moving towards conducting research in this area. In week 4, I looked at details of health insurance and market failures. And in week 5, I went into the issue of education, production function, demand for education, investment, whether we are looking at the spending on education as a form of human capital investment, or again, whether we are looking at it from the point of view of creation of minimum capabilities. So it is in this context we looked at, we understood some of the contributions by key thinkers like Schulz and Becker and Jacob Mincer in the domain of education. We looked into some of the empirical papers given by these pioneering economists in the field of human capital investment model. In week 6, as I was mentioning, we looked at this distinction between public goods and private goods. And it is in this context that we looked at externalities and education. A number of technical terms was discussed as a part of this week, like public goods, private goods, merit goods, positive externalities, negative externalities, and what are the different policy tools that are introduced to deal with these kinds of when there are externalities that are arising in the market. How do we deal with these externalities? One particular emphasis in this week was on the issue of higher education, and we discussed whether higher education is a quasi-public good or a public good or a private good. And we discussed some of the important aspects regarding what are the conditions under which we can consider higher education as a private good, and what are the conditions under which we can consider higher education as a public good also. And we also realized that the higher education as a commodity has some very unique aspects that leads not just to private returns to education, but also has collective returns to education. So in that sense, we wanted to look at the issue of how higher education is to be financed. Who should provide for higher education is an important topic that we covered as part of this week. In week 7, apart from introducing Sen's ideas on inequality of outcomes and opportunities, which I did in the context of looking at not just heterogeneity of human beings, but also looking at how different human beings come from different backgrounds, they have different opportunities, they have different life surroundings, and as a result of which it is not sufficient to just look at differences in incomes, but also look at the differences between the different socioeconomic circumstances that they come from. So in that context, I focused on heterogeneity of human beings and the multiplicity of variables in terms of which equality can be judged. Because often when we talk about inequality of outcomes, or we want to understand equality of different groups of population, there is a tendency for economists to look at only incomes. But while we are looking at incomes, we realize that we may not be dealing with this problem in a very egalitarian manner, because there may be disadvantaged groups of population who require some kind of unequal treatment in terms of providing better access to resources, providing better access to opportunities, only in that sense can we look at equality. So in this week, I introduced sense ideas of re-examining the concept of inequality from the point of view of egalitarianism. And I also introduced James Heckman's study on education inequality, which laid emphasis on the fact that inequality begins from the childhood, and therefore the focus should be on early childhood care and education. So all of these ideas was to make the point that when we look at education and health as investments, they are not just variables in the sense that they lead to increase in economic productivity or productivity of a country in some sort of a causal relationship, but there are intrinsic matters with respect to rights that needs to be taken into consideration. It is in this week that we also studied about we studied about equity in healthcare from the point of view of vertical equity and horizontal equity. We studied this index called the Kakwani's Progressivity Index. And I would like to detail upon the Kakwani Progressivity Index slightly in this live interaction also, where because this I believe is the week that you may be currently when you are during this second live interaction. So the KPI or the Kakwani Progressivity Index basically measures the extent to which healthcare finance departs from proportionality. So we are basically looking at whether the health financing is progressive, whether it is proportional or regressive, with the help of two curves here, the Lawrence curve, which plots income received by the cumulative percentage of population, and a concentration curve in terms of percentage of healthcare payments. We wanted to see what is the distance of the concentration index of healthcare payments from the Gini coefficient of income distribution. So that gives us a sense of whether or not our financing is progressive or regressive. So if we get an index value which is positive, which is greater than 0, then we conclude that healthcare payments are concentrated more among the higher income individuals than income itself. If KPI is proportional, then we say that healthcare payments are proportional to income, or in other words, everyone pays the same percentage of their income towards healthcare, irrespective of their status of income. And if KPI is less than 0, then we say that healthcare payments are more concentrated among lower income individuals. So this is one index which is used extensively in the field of healthcare equity or healthcare financing studies, which I introduced to the learners as part of this class. And so in essence, this is a simple analysis, but it actually gives us a sense of whether or not we are in a progressive system of health financing. And a progressive system is generally considered more equitable because it reduces the financial burden on lower income groups. And I hope that students who are moving towards research in the field of health and health particularly can make use of these simple indices to calculate progressivity in health financing at the subnational level, meaning at the state level or at the country level. So these kinds of measures can be useful there. In weeks 8 and 9, I focused on the health and education policies. With regard to the national health policy, although I discussed some of the older health policy and the new national Ayushman Bharat policy as well. However, my focus in this lecture was mostly to raise a few questions with regard to what are the general considerations, or what should be the general considerations that guide a national health policy. So, for example, should the system have universal coverage? And if it should be so, then has it been attained? Similarly, how should the government financing take place? What should be the scope of benefits and cost sharing in a universal plan? Similarly, we wanted to understand how does controlling of expenditures take place, and so on. In this context, I also compared some of these national health policies in India. Rekha, are the slides not moving? Are the slides not moving? They are moving, right? Okay, so in week 9, we focused on global disease burdens. Like what is the GBD study? We looked at some of the key metrics of GBD, like the disability adjusted life years in India, and what is the policy relevance of disability adjusted life years. I also introduced the learners to important reports. One is on the annual state of education report and the public report on basic education. So these are a few things that we have covered till week 9. So I invite learners to ask questions. If you would like me to go back to some of the slides that I have just shared with you, then we can do so as well. So then if there are no further questions, maybe we can end the session. I would encourage the learners to pose questions from these weeks on the portal, and we will take it up from there.